easier for me.
Good morning, everyone. I'm Kimberly Chalia with PHCA. Thank you so much for joining us for today's webinar. Part 1 of RoP 3 webinar series, How to Survive the New Normal, presented by Paula Sanders. A few quick updates to share before we get started. This webinar is being recorded and will be made available on the PHCA website. The webinar has been approved for 1.5 continuing education credits for all attendees. For those who provided a NAB number, credits will be uploaded shortly. We'll also share certificates for those in attendance. As we begin today, all attendees will be listen-in only mode. Please feel free to submit questions via the Q&A icon on your screen, and we'll be sure to answer as many questions as possible at the end of today's presentation. I'll now turn over today's webinar to Paula.
Thanks so much, Kim, and good morning, everybody. This is a 3-part series, so we're obviously not going to get to everything, and there's going to be some overlap because there are themes that weave through the new RoPs. But, you know, at last they finally have come out with these guidelines, right? We've been waiting for these since 2017. Can you only imagine what the state would do if you took this long to respond to them? It just is amazing how CMS has rules for themselves that don't apply the way they do for us in terms of timeliness. Today is really going to be resident focused. We're going to be talking about resident rights, admission, transfer, and discharge, person-centered care plans, and a little bit about the behavioral health provisions. As I mentioned, we're going to keep hitting on these same topics on the next 2 webinars as well, and tie them all together, hopefully, at convention in September. We'll talking, for those of you who aren't sure what you're doing today, we're going to be talking about the new State Operations Manual guidance at Appendix PP that goes into effect October 24, 2022. I can tell you that I'm already starting to see that some of the surveyors look at issues in a different light. The first area we're going to be talking to this morning centers on resident rights and the changes that have been made. And you know, CMS is really drilling down into resident rights, specifically in the area of behavioral health and substance use or substance use disorders. If you think that someone is using drugs or has illicit substances or guns, you may not search their person, their possessions, or their room unless you have consent from the resident or the resident's representative. Additionally, and we're going to talk about this next piece throughout the morning, there's an expectation now that your staff need to know the signs, symptoms, and triggers of possible substance abuse. And those things include changes in the resident's behavior, increased unexplained drowsiness, lack of coordination, slurred speech, mood changes, and potentially loss of consciousness. You know, they're expecting you to have Narcan or some other medications involved in case your residents do have a drug overdose. And we're going to talk about the almost strict liability that you're going to take on if you have residents who have a substance use disorder or opioid use disorder. If you have suspicions that visitors or your residents have brought illegal substances into your facility, you're expected to call law enforcement. CMS does not want you to be the police, but you're going to be held responsible if your staff fails to identify the risks and provision of supervision to residents to prevent accidental overdoses. And the surveyors, if you have somebody who has an accidental overdose, the surveyors are being directed to go back and look at F689 related to accidents and F740 related to behavioral health services. So you need to start thinking now, who are you admitting? What type of residents are you taking in? Are your staff competent to take care of people that you're taking in who have behavioral health issues or substance abuse issues? And what does your facility assessment say? And we're going to talk about the facility assessment requirements throughout this morning and our next two webinars as well. If you haven't already reviewed the new requirements, you still have until October 24th to do so, but come October 23rd, I would urge you to make sure that your facility assessments are up to date on the areas that we're going to be touching on. So for today, keep in mind the need to update regarding behavioral health services and substance use disorders. CMS realized that they had dropped off some information about changes in the smoking policy. Just another requirement under the resident rights that current residents have to be grandfathered and allowed to smoke in an area that maintains their quality of life and also takes into account non-smokers. If your smoking policies change, you need to make sure that the new residents are informed that you're a non-smoking facility at the time of admission. There's also new language in the state operations manual that addresses expectations for different forms of smoking, like e-cigarettes, and tasks that your staff would need to do in terms of making sure if residents need help changing batteries and the other aspects that go with vaping and those e-cigarettes. So if you are a smoking facility, I would urge you to have someone take a look at the language in F561 because there's additional information relating to smoking paraphernalia. F563, CMS has been very explicit in terms of your right, actually the right of the residents to receive and deny visitors, and also your right to deny certain visitations. But first, I want to draw your attention to the clarification that CMS has made that you're supposed to be allowing visitation during communicable disease outbreaks, but what you do should align with the CMS guidance and the CDC guidelines to allow maximum visitation. Having said that, you need to be aware that the surveyors will cite you if visitors aren't following your policies. So we have seen citations as recently as this month where facilities have gotten cited because visitors came in to see residents who were in a yellow zone and the visitor refused to put his mask on. In front of the surveyor, staff went in and said, "Sir, you have to put your mask on." He said no, and they get cited under F880 for an infection control violation. So, you know, a huge catch-22. You're responsible for those visitors, and you can't deny them, right? You can't say, if you don't wear your mask, I'm not going to let you come see your dying mother. So a huge catch-22. If you have someone who has a history of bringing in illegal substances, you can deny access, or you can require supervised visitation to those folks. You've got to have that documented though while you're doing that. Now, if you recall on the earlier slide, we talked about staff needing to know signs, symptoms, and triggers of possible substance use. Now at F563, CMS expanded that and says your staff should be evaluating the residents after interactions with visitors or leaves of absence if you have some suspicion that they may be using illicit substances. And specifically, if they're out on a leave of absence and you have some suspicion, your staff should know to be looking for changes in resident behavior, increased unexplained drowsiness, lack of coordination, slurred speech, mood changes, and/or loss of consciousness. Remember again, you cannot search without consent. And if you think there are illegal substances in the building, you need to call law enforcement. And I mention this because depending on your resident population, you may want to develop a checklist, right? A screening checklist for people with suspected substance use disorder so that your staff can look to show and that the people are care planned for these specific elements. Still under resident rights, CMS has tried to be helpful. So they have revised the guidance for the SNF Advanced Beneficiary Notice and the Notice of Medicare Non-Coverage to make it more consistent with the Medicare Claims Processing Manual. So there is language now in F582 that provides clarification for the Notice of Medicare Non-Coverage, which is the notice that the Medicare Part A coverage is ending, as well as the SNF Advanced Beneficiary Notice of Non-Coverage, which allows you to transfer the financial liability to the beneficiary. And this is all separate from and unrelated to the admission and discharge requirements that we're going to talk about next, right? So CMS has done an awful lot of revisions in the admission, transfer, and discharge regulation, not the regulations, but the guidance, right? So let's talk first. If you've got a resident who's been admitted for short-term rehab and your therapy group, your physician have decided that she's completed her rehab, you're ready to discharge her. And Mrs. Smith says, I don't care, I'm not ready to leave. I think I need more rehab. If you discharge her, that's considered a facility-initiated discharge. Even if the resident doesn't object, the surveyors may still look at that discharge to see whether or not it was facility or resident initiated. Okay, Medicare Ends, right? Happens a lot with the managed Medicare. The plan has said, I've only authorized 7 days for Paula, and Paula still needs long-term care services. You have to offer me the option to remain. You have to tell me I have the option to pay privately. You can assist me to apply for Medicaid and explain to me, right? Couple things. If Medicaid is denied, you, Paula, are responsible to pay for all days after Medicare ended. If you're Medicaid eligible, so your Medicaid's approved, but you don't have any more Medicaid beds for me, you have to tell me in advance I'm going to be discharged to another facility with Medicaid beds. But you can't discharge me for non-payment if I'm MA pending or if I'm MA eligible. So they've tried to clarify this and give the residents a lot more rights when the managed care companies are denying further stay if the resident still needs long-term care services. Now, the slide that I opened this section with was an ambulance, for those of you who have trouble seeing. And that's because CMS has gone through gyrations to talk about emergent transfers. These are considered transfers if I'm sent to the hospital because I'm expected to return, right? It's not a discharge. So if I'm being sent for an emergency to the acute care facility, we call it a transfer. However, I'm in the hospital now, and I was pretty erratic before you sent me to the hospital. That's why you sent me for mental change in condition, because I was throwing televisions, right? Now the hospital has gorked me up pretty well, and they say, Sam's nursing home, Paula's ready to come back. You have to evaluate me into whether you can take me back based on my current condition when I'm ready to come back. So if I am totally gorked out on medications that you're not allowed to give me because you're a nursing home, not a hospital, you can deny my discharge. You can say, I'm not taking her back because at the time of discharge, you still can't manage my needs. My medication needs are beyond what you're allowed to do, and the only way they've managed to control my behavior is through heavy-duty psychotropics. If, however, they manage to calm me down through non-pharmacologic interventions, so at the time of discharge, I'm as normal, quote unquote, as the next person, you have to take me back, because the evaluation on whether or not you can meet my needs is not what I was like when I was throwing televisions and was sent to the hospital. It's what do I look like now when the hospital's ready to discharge me back. The resident has the right to return if they appeal the discharge, unless the return poses a threat to the health or safety of self or others. And if you're going to deny me coming back because I pose a threat, you've got to sit down with your IDT and your medical director, the psychiatrist, psychologist, and the attending physician, and make sure you document very clearly why the resident poses a threat and you can't meet their needs. And we're going to talk about that in a few minutes here. As a reminder, if residents were sent to the hospital for routine or planned treatment, they have to be allowed to return. So just by a way of refresher, what are the allowable facility-initiated discharges? A discharge or transfer is necessary for the resident's welfare, and the facility cannot meet the resident's needs. The resident's health has improved sufficiently so that the resident no longer needs the care and or services of the facility. Now on this one, let's just put a little bookmark here, because you still have to find an appropriate location. If my health has improved so I no longer need skilled care, you just can't put me out on the curb, right? We've got to find an appropriate location, and I'm going to talk to you in a few minutes about some changes to the notice requirements for that. Now, if the resident's clinical or behavioral status or condition endangers the safety of individuals in the facility or the health of individuals in the facility, those are reasons 3 and 4. You can discharge for those reasons as well. You can also discharge for non-payment or failure to cooperate with the Medicaid process after reasonable and appropriate notice to pay, remembering though that you still have to make sure that if someone you're trying to discharge for non-payment and they have filed an appeal, which would be filed with the Bureau of Hearings and Appeals, they have the right to stay. You cannot discharge them while an appeal is pending. And in many cases, the ombudsman's office will file the appeal on behalf of the resident. So we are seeing active litigation in this area, something just to be alert for. You can also discharge someone if the facility ceases to operate. Now, CMS has given examples at F622 of how the actual and potential harm analysis comes in, right? Failure to permit the resident to remain in the facility or to document the resident's transfer or discharge and communicate necessary information to the receiving provider places the resident at risk for more than minimal harm. Harm can be psychosocial and or physical, and they reference the new Psychosocial Outcome Severity Guide, which I've given you the site to here. It's important to understand that there's been a lot in the news nationally about facilities dumping residents out of both hospitals and nursing homes. And this Psychosocial Severity Guide, let me just give you a little bit of prelude of what we're going to be talking about at one of the next webinars. But this psychosocial piece, you know, what's considered psychosocial harm for a resident who is non-communicative and severely demented, right? How do you know that person has some sort of harm? They use what they call the reasonable person standard. How would a reasonable person react in these situations? And some of the examples that they give in the F622 of deficiencies would be the failure to take a resident back from a hospital after they've been admitted for a behavioral outburst. When the hospital is finally able to transfer that resident and discharge them to another facility, it's much farther from the family. The resident goes into decline because they're not able to see their family as much. That's sort of how they're linking, you know, it's like dot to dot here. So they're giving specific guidance to the surveyors on how to start evaluating these failures to find a harm outcome. When it says that this places residents at risk for more than minimal harm, that means at a minimum, we're getting a D level. That's where these deficiencies start. There's no level 1 deficiency. Notice requirements before the transfer or discharge. You have to give notice 30 days in advance, unless the health or safety of residents, of individuals in the facility would be endangered due to the clinical or behavioral status of the resident. Let me pause here and tell you that CMS and the states are much more concerned about the health and safety of residents. They don't get as excited if you say this person is a threat to my staff. So if you're trying to discharge a resident for behavioral issues, always try to include some incident that's involved another resident. Likewise, you don't have to give 30 days advance notice if their health has improved to allow a more immediate transfer or discharge, if it's required by the resident's urgent medical needs, or obviously you couldn't have given 30 days advance notice because they haven't been in your building for 30 days. However, you have to make sure you're giving notice to the resident, the resident's representative, if appropriate, and to the ombudsman as soon as practicable before the transfer or discharge. So if you're trying to discharge somebody because they're a behavior risk, you've got to be giving that notice as they're going out the door, right? You can't give it to them when they're sitting in the hospital, because that's going to violate 623, which requires that notice to go as soon as practicable before the transfer or discharge. Here's a new change. The notice is supposed to contain specific discharge location, which is the name of the new provider or the residential address. Over the past, I can't tell you how many years, I know folks have been doing 30-day advance notice of discharge that says, and we will, social work will work with you and your family to identify an appropriate location. That's not going to work anymore under 623 because we have to include where are they going. And let's say Paula's nursing home has said, I'm going to take him, I agree to take her, I can handle her behaviors. So we do the discharge notice, and at about day 20, Kim's nursing home calls you and says, you know what, we can't take Paula anymore, something came up, and now you've got to send them to Sally's nursing home. And you send them to Sally's nursing home, but you have to redo that whole notice. And if the reason you're going to Sally's nursing home turns out that Sally can't handle my behavioral needs, that could be a violation. And that's going to reset the date and appeal rights for another 30 days. So they're really, really making it much more difficult to discharge residents. So we've been on for about a half an hour. I just want to refresh your recollection to what we started with, which is who are you admitting to your facility, right? We're going to need to pay a lot more attention to what are our capabilities for handling people who have behavioral issues in particular. Permitting residents to return, F626. You have to permit all residents to return, regardless of their payment source. Bed hold policies must provide that residents who want to return within the bed hold period defined in the state plan are allowed to return to their previous room if it's available. If they want to return after the expiration of the bed hold period, they're allowed to return to their previous room if available, or immediately to the first available bed in a semi-private room. If somebody is MA eligible and they have an outstanding Medicaid balance, you still have to permit them to return to the first available bed. Okay, so two things that we normally say we don't take a resident back. I don't have enough beds. I don't have the proper bed. I don't have a female bed. I don't have a male bed. If your argument is, I'm not taking this resident back because I don't have a bed, surveyors are going to look under 626. Did you give that person a proper bed hold? And did you hold it? Was there an available bed when the resident wanted to return? And was the resident allowed to return to the first available bed in a semi-private room if their other room was not available? More interesting is what they're going to do if you say, I'm not taking Paula back. I cannot meet her needs. Surveyors are going to ask, why can't the resident's needs be met? We all know that, right? That's why we're documenting why we can't meet Paula's needs. However, they're going to go deeper into your records, and they're going to be reviewing other admissions to determine if residents with similar care needs have been admitted or that you've permitted them to remain. Because what they're looking for is maybe you really have the capability to meet this resident's needs, and now you're not letting them back, and that's going to be a 626 tag. A lot to take in, and a lot of changes. Discharge against medical advice. This runs through 622, 623, and 626. Surveyors are being told to investigate situations in which the residents sign out of the facility or leave AMA. They have to thoroughly investigate to determine whether it was really facility or resident initiated. And they're going to be looking for evidence as to whether the resident or their representative was forced, pressured, or intimidated into leaving AMA, in which case the discharge would be considered a facility-initiated discharge and then not AMA. And they're going to be gleaning evidence from interviews with a whole host of people, as well as from the medical records. So, lot to take in this particular area. Well, let's turn now to comprehensive care plans, right? This theme we're going to touch on again later in another webinar when we talk more about trauma-informed and culturally competent care. But I want to just hit you first with 656. Comprehensive care plans for culturally competent aspects. The services outlined in the comprehensive care plan must be culturally competent and trauma-informed. That means if you're using a program that's just kicking out generic care plans where you personalize them with the person's first name, but you're not doing much else, you want to go back and make sure you're addressing the cultural issues. And we'll talk a little bit and make a little bit of sense as we go through this. But your staff has to be able, not only do your care plans have to be culturally competent and trauma informed, the staff has to be culturally competent to provide that kind of care, and they have to be able to interact effectively with persons from different cultures. They have to be, the care plans have to be respectful, as do your staff, and responsive to the health beliefs, practices, and the linguistic needs of diverse racial, ethnic, religious, or social groups. Seeing a lot of citations recently from Pennsylvania Department of Health related to whether residents have been provided with appropriate assistive communication devices or translators. So look at your facility assessment on this. Are you taking in people who speak whose first primary language is other than English? And what are you doing to make sure that you're meeting their linguistic needs? Same thing if you're taking in people who are severely hard of hearing. Are you providing sign language or TTD so that they can communicate? Same with other folks who might have other impairments. The care plan interventions have to reflect the residents' cultural preferences, values, and practices. These person-centered interventions may be related to race, ethnicity, food preferences, care preferences, language and communication needs, which we've talked about, religious preferences, cultural traditions, sexual identity, and gender identity, just as some examples. And in terms of religious preferences, if you have a large, even one, a Muslim who needs to pray several times a day, how are you accommodating that? What's that person-centered intervention to show that you're being culturally competent? Trauma-informed care plans, right? They have to address the history of the trauma. You're expected to collaborate with the resident, their family, and friends to identify and implement individualized interventions. And you have to make sure that your staff is able to recognize the interrelation between the trauma and the systems of trauma. And some of those symptoms could be substance abuse, eating disorders, aggression, depression, anxiety, withdrawal, or isolation from others. So those are some of the things that you want to consider. You also want to consider, what are the triggers, right? The care plans has to describe the corresponding interventions for care that are in accordance with the professional standards of practice and accounting for residents' experiences and preferences in order to eliminate or mitigate triggers that may cause re-traumatization of the resident. And when you read some of the examples that they've put in the state operations manual, in this section under 656 and some of the other related F tags, which we'll be talking about on our next webinar, they include things like knowing that someone has an issue with crowds and you taking them to a baseball game and the resident starts having problems because they're in a crowd, and you put the resident back on the bus, right? So you accommodated them at that moment, but the implication is they weren't care planned properly, because if they had been, they probably shouldn't have gone to the ball game to begin with, because they were being put in a crowded situation. So we're going to hit on some of these things later, but I did want to reference for your sort of teasing you along for the next two webinars, right? 699 relates to outcomes or potential outcomes. 726 is the knowledge, competencies, or skill sets of your nursing staff to provide care or services that are culturally competent and trauma informed. And then there's a whole separate 742 that talks about services for residents with history of trauma and or a history of post-traumatic stress disorder. So we keep those in the background, but I do want to share, one of the examples that they've given in the 2567, in the state operations manual, is the failure to honor a Muslim's dietary preferences. The resident was given pork, and when she realized she had eaten pork, she became distraught and lost a lot of weight, and it's an immediate jeopardy, right? So really looking deep at this cultural competency for the care plans. Next, we're going to talk about behavioral health services. There's a lot in here. At F740, CMS has updated and provided additional definitions, right? They've updated the definition of mental disorder, which they've done in other tags as well, to say that mental disorders are usually associated with significant distress or disability in social, occupational, or other important activities. Substance use disorder, the definition has been updated as the recurrent use of alcohol and or drugs that causes clinically and functionally significant impairment, such as health problems, disability, and failure to meet major responsibilities at work, school, or home. Once again, we see CMS telling you you've got to tie the behavioral health care needs of residents with a substance use disorder or other serious mental disorder to your facility assessment. If you have a resident who flags under SUD or mental disorder, you got to make sure it's in your facility assessment, and then you're taking it a step further to make sure that you have the capacity, services, and staff skills to meet the needs of these behavioral health residents. You have to also ensure that PASSAR screening is done prior to admissions. If the resident qualifies for the specialized level 2 services under PASSAR, the surveyors are going to go back and look to make sure you're compliant with 645 and 644. But I want to spend time talking about what do we do for the resident who does not qualify for specialized services, but they still need more intensive behavioral health services like counseling. If they need these specialized, if they need more intensive behavioral health services, you need to be able to demonstrate that you've made reasonable attempts to provide for and or arrange for such services. And you have to make sure that that's carried over into the resident's assessment, their care plan, and what strategies you're taken to arrange for such services. So whatever they are needing, you've got to make sure that's clearly identified and documented. Care plans for residents with an assessed history of a mental disorder or substance use disorder have to address the individualized needs related thereto. One of the things that we're seeing with greater and greater frequency is the surveyors going through the hospital records that you've included, right, when they come into your facility from a hospital. If there's a reference in the hospital records to a past history of suicidal ideation, you need to care plan that, right? They're going to say that you're on notice that that resident had a prior history of suicidal ideation. What are you doing to address that? What are your staff doing to monitor? You know, it may be a really old diagnosis, and a lot of times they are, because the hospital is recording everything that's happened in the resident's life if they've done a good social and medical history. But the assumption is that if it's in the hospital record, that's somebody who has an assessed history of a mental disorder or substance use disorder. You got to make sure that it's care planned. Now, CMS has recognized that facilities can use behavioral contracts as part of the individualized care plan to address behaviors which could endanger the resident, other residents, and staff. These contracts can also be a method for encouraging residents to follow their care plan. However, this is a direct quote from CMS, In some circumstances, using behavioral contracts to impose a system of rewards and or punishments could be construed as meeting the definition of abuse, which includes the willful infliction of punishment and or the deprivation of goods and services. I would urge you, if you're dealing with one of these sticky wicket type things, that you think very carefully about what you're putting into that behavioral contract, right? If you've got a resident who is using a motorized wheelchair and they're consistently going out of the building without permission and driving down the sidewalk, and you enter into a behavioral contract that says, if you do this again, you go through everything, but if you do this again, we're going to take away your wheelchair. Well, that could be a deprivation of goods and services, right? You can't just unplug their battery and leave them with no means of mobility. Could you put them in another kind of wheelchair? Potentially, but all of this has to be very carefully considered because of this catch-22 that CMS has set up, which is, yes, you can use these, but they may not be worth the paper they're written on in some instances. Additionally, residents have to have the capacity to understand the behavioral contract. So if you're trying to enter into a behavioral contract with somebody who's got a BIMS of 6, my guess is the state's going to come back and cite you and say, didn't have the capacity to understand this. This is a violation of 740. The contract can't conflict with resident rights or other requirements of participation, but it could address some issues. And I'm going to take the time now to go through some of the issues that CMS has recognized as being valid reasons why you might want to have a behavioral contract. Let's say you've got residents with a mental disorder and or a substance use disorder, and they're going to be at risk for leaving the facility without your knowledge, which could be considered an elopement at various times throughout their treatment, or if they're going through active withdrawal. So you could sit down with them and say, you have the right to leave, and that could be a leave of absence. And if you're going, there are health and safety risks of leaving without telling us. You have the right to leave AMA. But remember, back when we were talking about transfer and discharge, CMS is really concerned that facilities are initiating discharges and then trying to hide them as, well, this was the resident leaving AMA, right? So you can't restrict their right to leave, but the contract can distinguish between a leave of absence, an elopement, and leaving AMA. Again, though, you've got to go back to the first bullet on this slide, which is, do they have the capacity to understand the behavioral contract? But if you've laid out a good behavioral contract that explains a leave of absence, how is that different from an elopement, which is you leave and we don't know about it, and leaving AMA, there may be some ways around this that may help you in specific circumstances for individual residents. The behavioral contract for these folks may also include the efforts you're going to take to help them. And then we're talking specifically for residents with mental disorders and or substance use disorders, right? So what are the things that you could be doing? Individual counseling services, access to group counseling, and access to a medication-assisted treatment program if applicable. But keep in mind, right, the very beginning, They said, who are you taking in, right? Who are your residents? You may decide you don't have the capabilities to take care of people who have opioid use disorder, for instance, because Pennsylvania doesn't allow nursing homes to give medication-assisted treatment. Doesn't care to the Department of Justice has taken the position that the Americans with Disabilities Act, the ADA, protects people with opioid use disorder. And in April of this year, they published a pamphlet called the Americans with Disabilities Act and the Opioid Crisis, Combating Discrimination Against People in Treatment or Recovery. And their staked out position is healthcare facilities can't discriminate against people who have an addiction. So welcome to the catch-22, right? CMS is telling you, you have to really assess whether you're able to take care of people who have substance use disorders. And the Department of Justice is saying, well, of course you have to be able to do that, because otherwise you're violating the Americans with Disabilities Act. And there have been cases, I'm not aware of any in Pennsylvania, but I know there have been cases in other states where the Department of Justice has sued skilled nursing facilities who have said they didn't have the capability to take care of residents who had opioid use disorder. So something else to put on your tally, if you're keeping score of how many different ways the government gets you coming and going, I would put this on that list. If you suspect that a resident is engaging in substance abuse, you can increase monitoring and supervision of the person in the facility to maintain the health and safety of the suspected resident, as well as all residents, right? You can restrict or provide supervised visitation if the resident's visitors are deemed to be a danger to the resident, other residents, and/or staff. But note that first one, increased monitoring and supervision if you have reason to believe or should have reason to believe. You can do voluntary drug testing if there are concerns that suspected drug use could adversely affect the resident's condition. Voluntary means they have to consent to it. You can do voluntary inspections if there's a reasonable suspicion of possession of illegal drugs, weapons, or otherwise unauthorized items, which could endanger the resident or others. And you always have the option and the responsibility to refer to local law enforcement for suspicion of a crime in accordance with state laws, such as possession of illegal substances, paraphernalia, or weapons. Remember, these things are going into effect October 24th, so you do have a little bit of time here. Now this would be in the behavioral contract, right? So if you're putting this into the contract, you can say to the resident, as part of this contract, you are voluntarily agreeing that I can drug test you if I suspect you're using drugs, which could adversely affect you. And you're consenting that I can voluntarily inspect your person or your possessions or your room if I have a reasonable suspicion of the possession of illegal drugs, right? So it's through this behavioral contract that's specific to the resident that allows you to get their consent ahead of time through this contract to conduct those inspections and drug testings. The behavioral contracts, remember we talked about this catch-22. You can't put in the contract you agree that if you fail to follow the terms, I can discharge you. That can't be the sole basis, right? But if I can tie this into those other, any one of those other 6 that we shared several slides ago, you may be able to do a belt and suspenders here, but you can't just say in there, if you refuse to take my behavioral contract or you refuse to follow the terms, I have an automatic right to discharge you. The failure, the resident's failure to follow the contract is supposed to be treated like any other care plan intervention that needs attention or needs to be altered to meet the needs of the resident. The IDT team should work with the resident and the resident's representative to revise the care plan and the contract if there's been a failure of some sort. I would also urge you here to make sure you're reviewing your activities programs to include specific activities for residents with mental health and substance use disorders, which may require different activities than the ones you're typically providing for the rest of your resident population. And we'll talk again about activities because that's another new theme that's coming through the new SOM, looking very deeply in terms of what our facilities providing for services in the way of activities. New information included in F740 for behavioral self-services. There's a revision of depression as a major depressive disorder or clinical depression. Listing the symptoms: fatigue, sleep and appetite disturbances, agitation and expressions of guilt, difficulty concentrating, apathy, withdrawal, and suicide ideation. CMS points out that depression is not a natural part of aging. However, older adults in nursing homes are more at risk than older adults in the community for depression. So you want to make sure your staff is aware of what these symptoms are for depression. At F740, and we'll hit this again when we're talking about medications in an upcoming webinar. There's a huge caution against misdiagnosing anxiety disorders, schizophrenia, and bipolar disorders. They list the most common types of anxiety disorders in the new F740 guidance. And they also point out that schizophrenia has to be diagnosed by a qualified practitioner using evidence-based criteria and professional standards, such as the Diagnostic and Statistical Manual of Mental Disorders, the DSM-MD, and that has to be documented in the resident's medical record. They just can't write a diagnosis of schizophrenia without also explaining what it is that qualifies. What am I looking at? This is Paula's schizophrenia. It just has schizophrenia. And one of the reasons that they're doing that here ties in, as I mentioned, to this push to make sure people are being are not being prescribed antipsychotics, because there's some belief that our physicians are misdiagnosing people in order to give them inappropriate medications. Additionally, at the end of 740, there's a huge list of resources related to behavioral health care and services that I would urge you to start looking at now, because we're maybe 6 weeks away from the effective date of these new requirements. F741 talks about sufficient and competent staff and behavioral health needs. So we've already been dealing with the 741 tag. What's now been added is that our staff have to be both sufficient and competent to work with residents with a history of trauma and or PTSD, which means they have to have the basic competencies and skill sets to meet the behavioral health needs for these residents. And they have to have been assessed and have appropriately developed the care plans. The requirement already included residents with mental or psychosocial disorders and substance use disorders. So I want to just pause here if you're taking notes furiously to tell you, update your competencies, right? I'd go through 741 and make sure I've got every element. If I've got somebody with PTSD, do I have competencies on my staff that is assessing their ability to work with these folks, right? So this is the new addition for the beginning, at the end of October, right? October 24th. What else has been changed in 741? They updated the definition of mental disorders, which we've talked about in 740. They've updated the definition or provided a new definition for substance use disorder. They've also defined trauma, which is something that results from an event, series of events, or set of circumstances that is experienced by an individual as physically or emotionally harmful or life-threatening, and that has lasting adverse effects on the individual's functioning and physical, social, and emotional or spiritual well-being. Why am I pausing here? You got to make sure your staff understands what this is, right? This is a huge one, because the surveyors are going to be checking to make sure they can distinguish and they know who's been diagnosed with an SUD, who's got trauma or post-traumatic stress disorder, right? This occurs and is defined as occurring in some individuals who have encountered a shocking, scary, or dangerous situation. The symptoms have to last more than a month and be severe enough to interfere with relationships or work to be considered post-traumatic stress disorder. Now, here we go back to the facility assessment, right? Your assessment has to include an evaluation of the overall number of facility staff needed to ensure that a sufficient number of qualified staff are available to meet each resident's needs. And the assessment, your facility assessment, has to include a competency-based approach to determine the knowledge and skills required among staff to ensure the residents are able to maintain or attain their highest practicable physical, functional, mental, and psychosocial well-being and meet current professional standards of practice. How are you guys doing that, right? In addition, when you're doing that competency, you've got to make sure that your staff is being sensitized to the ethnic, cultural, or religious factors that have to be considered to meet resident needs, such as different activities, food preferences, and any other aspect of care identified. Additionally, your staff has to be aware of the disease processes and disorders that are relevant to each resident to enhance their residents' psychosocial, psychological, and emotional well-being. So think back to that example I gave of, you taking somebody to a baseball game, which could be a trigger, right? When you read through 740 and 741 and some of the other behavioral health cultural competency and trauma-informed care, FTAGs, read the examples. I think they may be very good training tools to use with your staff so that they can visualize what some of this stuff means. Because if you just give them this slide, they're going to look at you with deer in headlights and what are you talking about? But if you say, if you've got a Muslim or an observant Jewish resident, you're not going to want to give them pork. And what happens if you give them pork, right? That's a religious food preference, but it's more than a food preference. It's a deeply held religious value for some people, right? So you really need to start looking at that. If you're in a community where there is a large ethnic population, maybe you want to bring in leaders from those communities, from those cultures to work with your staff and provide services and programming for that ethnic group within your facility, but also not just for the individuals who fall within that ethnicity, but also for others, so that you're beginning to sensitize your staff as well as your other residents to these differences, because that's what CMS is looking for. Non-pharmacological interventions. These are all added for people who have behavioral and substance use disorders. Assisting the resident outdoors in the sunshine and fresh air. For example, in a non-smoking area for a non-smoking resident. Providing access to pets or animals for the resident who owns pets. For example, a cat for a resident who used to have a cat of their own. I would have thought they would have given a dog as an example because they're a little bit easier to bring around. My cat hates people, so some facilities have cats. That's a different one. They're not as adaptable necessarily to visits with strangers, but CMS specifically points out a cat in their example, not a dog. Assisting residents to participate in activities that support their spiritual needs. We've talked about that. If, one of the things that some facilities are looking to do is to establish a dedicated prayer room so that various religious groups can meet there at different times of the day. Assisting with the opportunity for meditation and associated physical activity. For example, chair yoga. Focusing resident on activities that decrease stress and increase awareness of their actual surroundings, such as familiar activities. Offering verbal reassurance, especially in terms of keeping the resident safe. Acknowledging that the resident's experience is real to her or to him. Utilizing techniques such as music, art, electronics, computer technology systems, massage, essential oils, reminiscing. Assisting residents with substance use disorder to access counseling. For example, individual or group counseling services, 12-step programs and support groups to the fullest degree possible. Assisting residents with access to therapies such as psychotherapy, behavioral modification, cognitive behavioral therapy, and problem-solving therapy. Providing support with skills related to verbal de-escalation, coping skills, and stress management. And I draw your attention to the fact that CMS specifically calls out there's a lot more new guidance at F679 and activities, which we will discuss at a future webinar. Now, I wanted to give you the hypo that the CMS included in the guidance on 741, because I think there's a lot to unpack here, right? This direct out of the State Operations Manual. The facility failed to have sufficient numbers of staff who had the skills and competencies to monitor a resident with substance use disorder and who had just returned from a leave of absence. What do we know right there? We had a resident, we knew he had a history of SUD, and he went out on a leave of absence. If you recall from a prior slide, we have to make sure we're monitoring them, right? Because we have reasonable belief that he had this history, and now he's come back from a leave of absence. Turned out the resident had a history of substance abuse and went on leaves of absence, and he had care plan interventions indicating to monitor every 15 minutes for signs and symptoms of substance abuse, which included changes in behavior, slowed respirations, and somnolence. Okay. Something must have happened to this resident because surveyors were looking at them. So they interviewed the nurse aide who was assigned to monitor this resident. The aide didn't know what somnolence was, nor could she state what a normal respiratory rate was. So what do we take away from that sentence right there? Don't write medical terms like that. You don't say monitor to see if they're lethargic, right? If they're falling asleep. Don't write a word that your aides aren't going to be able to understand, because the surveyors are coming in and they're going to ask them, this is what you're supposed to monitor. What does this mean? What does slowed respiration mean? How is this aide supposed to know what that means? Because she couldn't state what a normal respiratory rate was. You know, here's the next kicker, right? The aide also stated that he or she had never been assigned to this resident before and was unaware of the resident's baseline, of what the resident's baseline behaviors were. Therefore, the aide could not state if he or she had observed any changes in the resident's behavior. So, good news here from this, we're at a scope and severity of D, which means there was a potential for harm. But I can tell you, if this resident had overdosed, we're looking at a G or possibly an immediate jeopardy. And I could easily have converted this to an immediate jeopardy tag if it turned out that there was more than one aide who couldn't answer any of these questions, and if there had been an overdose, right? This looks to me like a D, only because they must have pulled somebody with a history of substance use disorder and looked at the LOA and dug into that slightly to see what was going on. But if there had been an overdose, and if the resident had to be revived with Narcan, what do you guys think, right? I would take this example, go back and look at what does your care plan say? How are you translating that all the way down to those frontline people so that they understand what they're supposed to be looking for? And also, what are you doing when there are call-offs and somebody new is working with that resident, I would like to think that you're taking your people with substance use disorders and making up that little cheat sheet that we sort of talked about. Saying, Paula has a substance use disorder. Her normal behavior is, come back and, sit at the TV or, pace up and down the hall, whatever it is. So there's something concrete that a new person can look at. So you have, that would be option one. Option two would be, if you've got people with substance use disorders, depending on your layout, are they all together? There's pros and cons to that. But look here, this is the only aide working in the unit when the resident returned from the leave of absence. There are problems all over the place. I look at this and say, okay, the D was a gift, but it's also a gift, I think, to your MDS coordinators and your IDT team about how not to write a care plan for somebody who has substance use disorders, right? It's quite possible that some of the, what I would call canned care plans, are going to kick out interventions like this. You got to dig a little bit deeper, guys, and say, is my staff going to understand what this means? Because that's what we're talking about at the end of the day. What's in your facility assessment about the folks you're taking in, and what are you doing to assure that you have enough staff with the competencies to take care of them? And part of that competency goes to the people who are writing these things to make sure that they're written in a language that your staff can both understand and implement. And on that note, I noticed that folks have been sending in questions and raising hands and stuff. I do want to remind everybody to register for the next 2 PHCA webinars on the requirements of participation. The next one is August 25th, and then the third one is August 30th. And then, join us at the PHCA Annual Convention and Trade Show on September 13th and 14th. We're going to be doing a requirements of participation wrap-up on September 13th, where we're going to try and sort of weave this all together at a much higher level to give you an overview. But the next 2 webinars are each 90 minutes. So we'll have a lot to go over in each one of those sections, including discussions about the changes to abuse and neglect reporting requirements and definitions, and a bunch of new stuff on QAPI. So with that, Kim, I'm happy to take questions.
Yeah, perfect. Thanks so much, Paula. We'll open up the Q&A session now. I do see there are 2 questions that have been submitted. Paula, are you able to see the questions?
I'm not sure that I can. Let me see if I can find them. Here we go. With regard to ADT, how is eligibility defined when determining discharge of a patient? If the family patient does not want to disclose their financial information, would the facility be unable to determine if they're eligible? Please clarify the definition of eligibility. Sure, Jennifer, I'm happy to do that. When CMS uses the term MA eligible, that means they've been approved for Medicaid, right? If the family is non-cooperative, along the way, you can move to discharge them. So I hope that helps. The eligibility doesn't mean I'm likely to qualify. It means I have qualified. The next question is regarding bed availability for lack of available beds for resident return. If the facility has a closed unit, will the surveyors identify those empty beds on a closed unit as an available bed? They should not look at those as available beds because they're not staffed. However, you do run the risk that if you have a closed unit at some point, if it's been closed for a really long time, the department may look to have you remove those beds from your license. But in the ordinary course, especially now when people are having so many challenges with staffing, you know, if you don't have the staff and it's a legitimate shut closed unit, that's not going to be an available bed. You know, I think what they are looking at, and we've seen this happen before, somebody, you know, the hospital calls and says, Paula's ready to be discharged. And you say, well, I don't have any female beds, sorry. If my family complains to the state, they're going to come in and say, you know, Paula called, her family called on August 15th. I want to see your census, right? So I think that's where you're going to get hung up in terms of available beds. Maybe a little bit different right now as people are having COVID units, and there may be some issues with that, but in general, that's what we're talking about with the closed units.
And that is all of the questions in the Q&A section. I do see that Mary has her hand up, so I will push to allow Mary to ask her question.
Sure.
Okay. I guess, Mary, if you do have a question, I didn't hear you chatting, but if you do have a question, feel free to submit that in the Q&A icon. Does anyone else have any questions today? If you do happen to think of something after today's session, please feel free to email myself or Paula. We're happy to answer any questions that come our way. And again, thanks to Paula for sharing this important information today. And thank you everyone for joining.
Thanks, everybody. We'll talk to you in a few weeks.
Thanks, guys.
Okay, thanks. Bye-bye.